Thank you very much, Dheeraj. So we begin a very important session on avoiding complications in lumbar spine surgeries. Lumbar spine surgeries, as we all know, are one of the most commonly operated spine procedures, and purely by number and statistics, there could be an increased incidence of complications in these cases. So if we go to the cases, if we go to the session, basically whenever a patient comes like a disc or canal stenosis, there are certain clinico-radiological factors which help in decision making, and based on that we decide whether we want to operate or not. And basically there are two types of surgeries in the lumbar spine. One is a decompression surgery and the other is a fusion surgery. So in this particular session, we are going to have a few case discussions on which the esteemed panelists and the case presenters are going to throw some light on this particular issue. I would like to invite Dr. Deepak Joshi to have his talk on decompression in lumbar spine.
Good evening, dear teachers. Good evening, my friends. So I'm going to talk about ideal lumbar decompression and avoiding complications in decompression. I believe that lumbar decompression is the most rewarding surgery in spine surgery if indicated, and it can give results equal to a total hip and total knee replacement. When the results are good, the expectations are high, which means you have to do a perfect or near perfect job. I'm going to present a case, a simple case, bread and butter case of 59-year-old male with history of back pain, both leg pain, and he has been doing well for 5 years. Now for past 4 months, he has new numbness in both the legs, and it has no fixed dermatomal distribution. He has decreased standing, decreased walking, and is disabled. And for past 10 weeks, he has bilateral severe radicular pain and L3, L4 distribution, and there is no relief after conservative management. This is the X-ray, and we can see that there is a sacralized L5. And these are the images of the lumbar spine at L1, L2, L2, L3, L3, L4. And majorly compression is at L2, L3, and L3, L4. It is sacralized L5, so that is, and this is the L4, L5. And we can see there is slight lateral recess compression on the left side. And this patient also had a bilateral foraminal compression. So I would like to, there is no doubt now that the patient is disabled, he needs a surgery. I would like to ask the chairpersons that how would you go about, this patient needs a surgery. Is there anything special in the position which we would think of in such patients? Do we have any preference for flex position, extended position in such lumbar canal stenosis patients? Sir.
Definitely, if we are doing at the lower lumbar region, the position plays an important role, because I would like to do it, I do scopically. So we flex the spine at the lumbar spine so that the interlaminar space opens up.
Yes.
I think that will also hold true for that.
Any other idea?
Hello. So I prefer to do all my surgeries in the lordotic position because that's the physiological position. And when you get finished the decompression, it's a physiological state.
Right. So I think, yes, the flex position definitely gives a lot of advantage because it opens the interlaminar space. But in the lordotic position, if the patient has stenosis, we get more of a functional idea how the patient is going to behave after the surgery. We can have a flex position, the foramen can open artificially, and we can get a false impression of the this. So, this is a case, very simple case. Everyone will see this case in the OPD and they will advise a surgery. My plain questions are, what would be the surgical plan? How many levels? Which approach? Open, MIS, tubular, endoscopic? Or, does one approach has more advantage over the other or not? Yes, sir.
I think what you ask is important, because in a canal stenosis, we want all the offending structures to be visualized. So we do it in extended position. Regarding the surgical plan, the the point is he has a back pain, so you need to rule out the instability by doing a flexion extension X-ray as well. And if there's a significant mechanical back pain, then it go on a fusion. If there is not much a mechanical back pain, then I would proceed with the simple midline decompression, which would be facet preserving, and pars should be well maintained during the decompression.
So flexion extension X-ray I have not put up, but there's no instability, and his back pain is more like a lower back pain, buttock pain, referred or radiating pain rather than a mechanical pain. So what would be your surgical plan? Would you just decompress 1 level, 2 level, 3 levels?
So the plan will be here the maximum offending structure is at the L3, L4 and L2, L3 level, which is kind of atypical because he has a sacralized L5. So I was expecting more chances at L4, L5. So I would do a limited decompression spanning at most 2 levels depending on my intraoperative finding and the clinical symptoms.
Sharan, sir.
See, this is, I think it is at a higher level, and if I have to do this scopically, I will do it transforaminal. I'll clear it out. What is the age of the patient?
59-year-old.
59 years old. So I would also do a flexion extension X-ray and also assess him clinically. If it is more, then I would also not hesitate to open it and do a good decompression.
So Deepak, if here on this side, yeah. So assuming that we are operating on this particular case right now, I would like to ask ABG sir, if you look at the X-rays, this patient shows that there's a little bit of congenital canal stenosis, like it's a very narrow canal. So in this case, what are the precautions that you would take to prevent iatrogenic instability while doing your decompression?
Yeah. One point before I answer your question, want to make it clear, all lumbar canal stenosis, degenerative, must be operated in extension. Simply because the patient get symptomatic in an extended position, and so you give that particular position. If you do it in flexion, you are likely to do under decompression. So that part must be kept in mind. Secondly, L3-4 decompression, if the patient has a localized symptoms which correspond to L3-4 and no instability as per the X-rays and everything on a stress view, then I think only the junctional decompression is good enough. You have to be very careful about, because the canal is stenotic, careful that dural leak do not happen. That is the most important thing. And see to that all the nerves are completely decompressed.
Sir, as this is actually L2, L3 because this is sacralized, and any special precautions we need to take as we go up because, the interpedicular distance is less, so we might just cut off more facet and cause instability.
Yeah, like a 4-5 and 5S1, we have adequate space available. And the pushing of the cord is not a major issue. But at 2-3 level, you should not do that. No pushing of the cord at all. Most importantly, do the decompression using a laminectomy. At the same time, undercutting of the facets. At the same time, you should never do the pushing of the cord the way you handle at L4-5.
Sir, any particular technique in which you undercut the facets, ABG sir? What do you exactly mean by undercutting the facets, just for the sake of
If you look at it on table, you'll find that the facets which are hypertrophic, all these patients, and a part of a facet, we don't want to take out a whole facet which can make it unstable. So part of a facet which is encroaching into the canal, which is a part of a facet, not the whole facet, that part only you should remove it so that the nerves become decompressed.
So what would be the sequence of decompression? Central, lateral, and then foraminal, and how would you go about it, Badani sir?
So first I do a complete central laminectomy. Not a very wide one, and I leave about at least 6-7 millimeters of the pars area. And then I cut more if required. And then as Dr. ABG was saying, I do undercutting of the facets such that I preserve most of the posterior and the posterior lateral part. Only the anteromedial part it goes, and just as much as is needed with it, sometimes with a 2 mm kerrison, and just make sure that adequate space is made. So first the central canal, then the lateral recesses.
So Badani, any particular sequence of doing a flavotomy in your case? how do you actually make an incision in the ligamentum flavum when you do a decompression?
Yeah, so what I do is I use a scoop, and where the ligament attaches in the proximal lamina, I use the scoop like a periosteum elevator, and I scoop under till it is released from the proximal lamina, and then I negotiate a small nerve hook inside in the median raphe and give a little tug. So the median raphe separates. Then I can put a dura retractor over it, either a small one or depending on how much space is created, and then use a 15 number blade to cut over it. So I cut the ligament right in the midline, and then you can use kerrison to remove the rest of the stuff.
How many of you would also do a discectomy in such cases? APG sir?
Most of the time it is not required in a patient with a degenerative stenosis. It's encouraging the canal, but most of the time nerve roots and everything is free. So unless the nerve disc is soft and causing a tenting of the nerve root or causing some pressure on the nerve root or decreasing nerve root mobility is decreased, then you should think about it. Otherwise, no.
So I have to add something
Yes,
that what I look for is the new symptom developing in the short span of time. Could be a disc prolapse. Any nerve tension signs along with the patient, like the femoral stretch SLR, that indicates that the additional component has developed. That I keep in mind, and then of course we follow the rules that it is not significantly offending the nerve root and it is a gentle bulge. We leave it.
So we correlate the clinical picture with what we see on the table and then decide. But discectomy is not required in all cases of lumbar
Really not
stenosis.
required.
That is very important point.
Unless there is a small fragment that has come.
Yes. So Badani sir, what would be the end point of lateral recess decompression for you? When would you stop? Yes, that's enough.
So proximally I go till the facet joint. The facet joint should be, you go a little beyond the facet joint. Distally, I ensure that I can put a circular probe, the root probe into the foramen outside sufficiently, and or you have a retractability of about 1 centimeter of the root at the level of the proximal body or the disc. That is sufficient.
Sharan sir?
I agree with him. Just like in UB, you start and you go and see the nerve root from the axilla till the shoulder, and you see that it is clear. You needn't mobilize it, but if you are able to see it clearly, that means you have done enough decompression.
A 2 millimeter probe, you should be able to pass through the foramina comfortably.
Anything you want to
Arjun,
add?
a question for Dr. Arjun Dhawale. In this case, if you find that you have, in the process of doing a lateral decompression, you find that you have excised too much of pars, then what is your decision on table? I mean, do you still want to conserve it, or you want to go in and instrument it if you create an iatrogenic pars instability on table?
So I'll always keep the instrumentation available for every case, and definitely I'll fuse it.
So all stenotic canals, you keep your instrumentation
Yes.
ready.
Yes.
Right. So Deepak, do you have any literature on this? Would you like to sum up?
Yes. So, anyways, these are another things. I just summarize. I just did as L2 to L4 decompression, bilateral and nerves were free. So, lateral recess decompression is important because that's just clinically significant part. And for facetectomy, we have to make sure that not more than 50% of the facet is removed bilaterally. Complete facetectomy, unilateral or bilateral, is totally contraindicated. You have to keep 8 to 10 millimeter of pars on both sides, especially in osteoporotic patients. You have to be careful. The good decompression or endpoint is pedicle to pedicle decompression, both cephalocaudal and sideways, because then that is the point when the bone will not re-go again. Discectomy we have discussed, and this is one important point in complication which I would like to discuss is a wrong level surgery. And I always have 3 checkpoints, one at the skin incision and one at when I'm before cutting the lamina and then before I come out. So I think that was from my part.
Any precautions that you take to prevent excessive bleeding? Any particular areas where you want to see the bleeders when you are doing a decompression?
So, for the bleeders, there are 2 areas where there is a lot of bleeding. One is lateral to the pars and lateral to the facet. So you just don't poke anything over there. And I think good positioning when you have abdomen free and good dissection where you don't go through the muscle but erase it subperiosteally is the key. I think spending time 5 minutes extra saves you a lot of burden later on.
Right, right. So those are very important points. You have to be very, very meticulous in your exposure when you're doing
One more point I want to say, which we do the mistake so we use a bipolar cautery to control the bleeders. It is easy to bipolar over the disc. If we go proximally or distally over the bones, then you get lost and you cannot control the bleeding. So one has to be mindful of this, that when we are bipolaring, we see it and then do it rather than, we are lost there.
Right, right. So very important points that you have to be very, very meticulous in your exposure and your discectomy and decompression. Right. Thank you very much, Deepak. That was a very, very interesting case. We now move on to the first talk, which was by Dr. Arjun Dhawale on decision making in lumbar canal stenosis and disc prolapse.
So I'm sorry I was held up in a session below. So I'm going to be briefly, taking you through a case with a lumbar disc disease and recurrent symptoms and the decision making, with the help of the panel. So this was a 48-year-old active female. She came to the clinic in 2018. She was initially looked after by Dr. Kshitij, my colleague at that time, and then subsequently by me after he moved. So she had low back pain with stiffness, intermittent episodes of severe back pain. She was neurologically normal, treated conservatively with rest and physical therapy. This was her initial MRI in July of 2018. I'm going to move forward, so there's a 4-5 disc here, So the patient got no relief with conservative treatment, pain increased in severity, there was radiation to the right thigh, neurology was still normal. And this was the next MRI which was done in October 2018. So I'd like to start. I'm going to go with one question to each panelist so that we save time here. So I'll start with Dr. Deepak first, and we'll just go sequentially. Your findings and what would you like to do?
So there is definitely decreased disc height at L4, L5, degenerated disc, and there is central protrusion. There is no severe, any lateral recessed stenosis we can see. These are very critical, difficult patients because we really don't know what exactly the source of pain is, whether it's a discogenic pain. I try, if you ask me what I do in my practice, I just keep on treating them conservatively and then give an option of a discography.
Sir?
Yes.
What would you like to do here?
If the patient has no neurological symptom, and I don't think the patient will have backache also. So as far as possible, you treat conservatively.
Okay.
The time comes when the patient start complaining neurological symptom, tingling, numbness, weakness or something like that. Only then you have to intervene surgically.
Okay. So the patient got no relief with conservative treatment. So she went in for a CT-guided L4-5 epidural steroid injection. And she was symptomatically better for a few months. Then she had intermittent severe worsening of the right leg pain after 3 months. SLR was positive, neurology was normal. She was advised to continue physical therapy. 9 months post-epidural steroid injection, she presented acute back pain again, severe right leg pain, unable to stand and walk. Neurology was still normal. This was her X-ray. Any comments on the X-ray, Dr. Sharan?
Just going back to the pre-op, the first MRI cuts transverse which you had shown. On the right side, there was a disc on the traversing route at that level, at the upper end. So we could see a disc probably that has exaggerated over a period and that is presenting as a symptom.
Yeah. So that disc has progressively increased. You saw the increase in the size of the disc in the sequential MRIs. Now, this is the X-ray, with the findings of the list. I'm going to go to the MRI picture. That's the MRI now.
Yeah.
What would you like to do?
Now you can see that there's a clear migration of the disc behind the L5 body, and it is clear cut right-sided. Now it has become an extrusion because so this is and this is almost 9 months and it is not relenting. So here we would counsel and talk to the patient and offer an option of microdiscectomy as the pain is severe and not responding to conservative management.
Okay. So that's what was done. L4-5 microdiscectomy. There was no instability on the X-ray, so only a microdiscectomy was done. Post-op period was uneventful. She was discharged on third day. Significant right leg reduction in the pain. So patient was better for 3 years. Then she again came back. Presented with low back pain, severe right leg pain. She was clinically neurology okay, but right side SLR positive. Treated with IV analgesics, rest, physio for 2 weeks. Pain settled a bit. This was her X-ray, Feb 22. Any comments, sir?
The L4-5 disc height seems to have reduced considerably compared to before. And nothing else, I think, specific.
I feel you should have taken a stress view in the beginning.
Okay.
I
So,
have a doubt whether this is unstable segment.
the question really is in a patient with acute pain, does the flexion extension X-ray really help? Because, patients can't freely move. So there is a limited information one can get in a patient who's already in a spasm with a flexion extension. But yes, so when we are looking at a supine MRI versus a standing X-ray, which also gives us some information without, especially if a patient is in discomfort. So what is your thoughts, sir, on that?
The patient in a lateral position of flexion extension lying down.
Okay.
It is possible.
All right. So I'll come to this side now, so Dr. Sonone, so this is the MRI now.
So the MRI shows that there is, what you can see on the MRI are changes which are because of a degenerative condition, the modic changes, and there is a reprolapse. So this is a reprolapse because the patient had an interval period in between, and there is compression on the left side. This is, if the MRI is put up properly, it's maybe it's on the left side, because this is how it is usually, right side.
Right,
So
right.
compression is on the right side. Again, I would in this case, because the patient is significantly disabled, first is I would definitely try to give a root block in this case, because the patient doesn't have any neurological deficit, and then explore my other options later on.
Okay. So this was relapse of pain after initial reliefs, the relief, excruciating pain. So again, as you correctly said, we did a CT-guided epidural steroid injection at 4-5, right side. She had symptomatic relief for a few days, followed by severe right leg pain again. Again, we did a repeat MRI. This is the MRI. This patient is treated now recently, 2022. So now, what would you like to do?
So I think in this case, I would not actually go in and get a repeat MRI, because I don't expect to see anything else apart, unless I'm suspecting a disc prolapse proximally or distally. Now surgery for disc prolapse is basically surgery for pain. The natural history suggests that it is going to resolve over a period of time. But in this case, it's a foraminal disc. There is severe compression on the root. The patient had responded to the epidural steroid before. That means that is the site of pain. And in this case, I would definitely consider doing a decompression / fusion, depending on the patient's back pain.
Definitely going for taking dynamic X-rays, lateral views, and since this been a revision surgery, a second surgery, reprolapse of disc, we definitely opt for fusion.
So I'd like to have a vote on this. How many would go for a repeat discectomy here, and how many would go for a fusion? Everyone can just comment.
No, this patient particularly, I don't know why two times epidural was given. And again, in spite of that, we are thinking about conserving. Correct?
No, I'm not telling you that. So basically the patient was given epidural after, when the first episode happened, and has been given epidural second time after the recurrence, 3 years after the first surgery.
Exactly. We are treating with the epidural.
Yes, one epidural after the recurrence and one epidural after the primary episode.
So I want to ask question. Why you have to keep waiting such a long time when you know that the patient is not responding and epidural is not a treatment? Root block is not a treatment.
So patient had no neurology. Patient was only having radicular pain, and patient opted for conservative treatment because she didn't want to have another surgery, because she had reasonable relief for 3 years and she had a recurrent episode after 3 years.
So Arjun, if I may just cut in, I think the question right now in our minds is whether to do a decompression only or a fusion, right?
That's correct. My
Maybe
question
we can-
is decompression only, repeat discectomy, or a fusion? Yes.
Decompression fusion.
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 I will do just a decompression and lateral cyst, because there's no back pain you are saying. You are consistently saying there's a right lower limb radiculopathy. and not much of a back pain. So I would still give a chance to do a decompression.
Sir?
Fusion.
Okay. Fusion, so
body.
will you just do a posterolateral fusion or will you do a T-lift?
No, I will do
So,
interbody
Dr.
fusion.
Arjun, if I can just interrupt, for the fusers, may I just ask a question? Why do you feel the need for a fusion, Dr. Badani, in this particular case? The patient doesn't have any back pain. The patient just has got radicular symptoms which are a recurrence of the same symptoms.
I don't want her to come back a third time for the same disc.
So, is there any assurity that the patient won't come back with an adjacent segment if we fuse it?
She'll come back after many years.
Right. Okay.
So the guidelines are that you can do a second discectomy. So for a first recurrence after discectomy, you can go and do a second discectomy, or you can do a fusion based on, of course, the clinical scenario, clinical presentation, etc. Okay. Would anyone do a CT scan?
See,
Yeah, I think I would do a CT scan because if you see on the MRI, the facets, it always depends on what sort of decompression was done in the first stage. Was it a microdiscectomy or open one?
Tubular
Here you can see that the facets are quite okay, right? That means there's no lateral recess decompression per se, or it was not needed probably. Now in this case, if the CT shows that the facets are all intact, you can still go in, do a 1/3 of medial facectomy and get that fragment out without actually fusing this patient.
Okay. So I'll cut this. So in view of the consistent and severe right leg pain, right side EHL weakness which had developed, she was planned for a L45 T-lift. And, she was better after the surgery. Okay. This was her immediate post-op. And basically she had a calcification in that disc. So the nerve root was inflamed and that disc was calcified. And, the T-lift approach did help to actually protect the nerve root which was already having adhesion, from injury. So taking a T-lift approach actually helped to prevent a post-op radiculopathy here. Because otherwise with the adhesions and with that calcification around the disc and the epidural fibrosis, there would have been a post-op radiculopathy here. So that was the approach. And this was 6 months post-op. It was, and the patient is actually doing well. Right leg radicular pain has improved. Clinically, SLR is negative, normal neurology, and, hoping that there's no adjacent segment disease. But any comments from the panelists on this and, criticism or whatever you would like to say?
If you see the MRI before you did the first surgery, you would see two shades in that. One is dark black disc prolapse and a grayish disc prolapse. So that it was calcified right from the beginning. So the first two MRIs were basically showing it central calcified disc bulges. There was no significant disc prolapse in the beginning.
So it was not calcified in the first surgery because I was there for it and there was no calcium. It was a soft disc the first time.
No, this is before the surgery.
So this is the first MRI?
There is no calcification there. Now look at this and next one.
Okay.
Next one. See this. In the center you see a dark shadow and then there is a grayish. That gives us an indication it might be calcified there. Or there was no calcification.
No, there was no calcification at that.
so it's always important to do a contrast MRI in a revision spines just to understand the scarring pattern and the calcification. So once the patient is operated, it is always better to ask for a contrast.
Any comments from the senior faculty about, what could have been done differently or?
Whatever is done is absolutely perfect. She needed fixation along with the fusion and a decompression, of course.
I agree.
Thank you. Thank you very much.
Thank you, Arjun. That was a very good case. Now we move on to the one case on what are the, we already seen that there's a lot of talk of fusion surgeries and aggressive fusions in canal stenosis and what can exactly go wrong. It is all not a piece of cake. And we have Dr. Tushar Rathod who will take us through a case of a complication in a fusion surgery and what are the ways and means to avoid it. Dr. Tushar.
We had follow-up, so I showed it.
So I'm going to discuss in the form of case presentation where we are going to discuss what the panelists would like to do. So it will be interesting and no theory. So we had a 35-year-old female who came to us with a low back pain which was there for a period of 6 years. She had a claudication which used to start after 10 minutes of walking. There were no any comorbidities like diabetes, thyroid and hypertension. On neurological examination, there was only left-sided EHL weakness. Apart from that, rest of the neurological examination was unremarkable. So it was a more of a central canal stenosis features. The peripheral pulsations were well felt and you can appreciate on the X-ray that there is some right-sided curve. So at this point, I would like to know from Dr. Sandeep any findings on X-ray. What would you see with this symptom and complex?
So again, there's not too much to comment on the X-rays apart from a little bit of scoliotic curve on one side, but there's not too much over here because the disc space appears normal, the foramens appear normal except for some foraminal stenosis at L4 5 maybe, but otherwise the X-rays look quite okay to me.
So I would reframe the question. If you, in case hypothetically, if you are planning for a fusion, and if these patients, a lot of time elderly do have some degenerative scoliosis, does it make any change in the plan when you
So
are
again,
approaching this
the
case?
radiology probably would not matter too much. It depends on the clinical symptoms. So always have a look at the amount of back pain, whether the patient is coming to us with back pain and radicular symptoms and difficulty in walking, or difficulty in walking is the first symptoms and then you are eliciting this history of back pain. So again, as ABG sir said, dynamic X-rays would definitely help. Uh, there's a possibility that there may not be any translational instability, but yes, there could be retrolisthesis, which is a sign of axial instability, and also there could be opening up on flexion extension views, which is again a sign of angulatory instability. So all these factors, along with clinical features, would definitely add to my decision making.
So it's a very important point which you highlighted, degenerative retrolisthesis, which could be very well a sign of a transient instability. Now this was the MRI. These are the cuts which are going from left to right, and you can appreciate that there's a foraminal disc as well as the central midline compression. I would like to come to Dr. Deepak. What do you see on MRI and what are your findings?
I saw what you already told. There is a central disc and lumbar canal stenosis centrally as well as in the lateral recess, and some foraminal disc which is touching the nerve in the foramen, mostly in the medial side. And rest of the discs are fine, the above and below, so that should not be a worry.
Right. So these are the axial sections and these are the flexion extension X-ray. I would like to ask ABG sir to interpret for us. This is a localized L4, L5 stenosis, and this is the axial section with a flexion extension X-ray.
It looks like a more opening and a L4-5.
Yes.
Suggestive for instability.
Right.
Secondly, the MRI decision of surgery is not by MRI. MRI, they never says to go for the surgery. It is a patient symptom and the deterioration over the period of time. So progressive symptom may be development of the deficit and patient difficulty in doing daily activities. That's the time you should intervene rather than looking at the MRI.
So these are very wise words from a veteran surgeon, more importance to the clinical finding rather than the radiology itself. I will proceed, and we did this fusion for the patient. We offered L4, L5 transforaminal lumbar interbody fusion from the left side as the patient had left side weakness. Dr. Sudhir Sharan sir, what is the, how do you read this X-ray post-operative?
I think this is a good surgery. Only thing, the cage should have gone little more anterior. And this is well done. I think the pain has gone over a period of time, it will do well. Okay. Only transitional degeneration might happen later on.
Okay. I would like to come to Arjun. How do you decide and assess the cage height? Is it all intrafield or do you have any other specific methods? And do you do TLIF or do you do PLIF, and how do you decide that?
So yes, it is the intraoperative field, the preoperative planning, the intraoperative field, and the intraoperative check, with the spacer. So when you put in the spacer, are you feeling that there is good contact with the end plates? Are you getting a good feel? Then going for an adequate sized cage. It has been shown that using an oversized cage also is not good, and neither is undersizing it a good idea. So, and I think the option of whether you want to do a TLIF or a PLIF or a posterolateral is basically very much technically dependent on the comfort of the surgeon and whatever one is comfortable doing.
Right.
All are equivalent.
So next question to Dr. Badani. Now there's a lot of talk on the lordotic cages. So what is your take? Do you still prefer this kind of cages or do you prefer banana cage? What is your preference with respect to cages?
I use, if available, I prefer to use lordotic cages. 4 degree and 8 degree cages are available. And I tend to go for a size that is just enough. It should not be over restricted nor under. and I use the lordotic cages because it try to restore some amount of normal lordosis.
Okay. So again, the cage, there are always, the implant wala gives a choice. Sir, there are 18 cage and there is a 22 cage. So what is your take? Do you prefer a longer cage or you want a shorter cage? So how do you decide about that?
So I think in this case, see, it depends on what the patient is coming with. For example, if the patient is coming with a grade 2 listhesis, you don't want to push in a 11 number cage because that will put too much stress on the end plates. So in that case, maybe a 9-10 number cage should be more than enough. But in these cases, minimum is 11 number cage, which I would like to prefer. Again, it comes in sizes.
Two sizes,
That's
yes.
22, 28.
Yes.
Again, I would prefer that the cage is actually sunk in quite well, and I don't remove the whole of the osteophyte of the posterior margin of the body. So that once I put in the cage inside, I compress posteriorly so that the cage is locked. So less chance of the cage backing out. No, so these things are very important. Again, I prefer a bullet cage because I find putting in a banana cage a little cumbersome. Bullet is much easier, and also it gives a good trajectory for me to go right into the center of the disc piece.
Okay. And our next question to the chairperson. When you are doing this compression, decompression from the one side, there is always a talk of indirect decompression which happens on the other side. So do you routinely do a fascectomy on the opposite side? Do you decompress that side for this kind of a symptom complex, or you restrict yourself to the one side only?
If there are unilateral symptoms, it's better that we decompress from the opposite side, on the same side, and we are thorough enough and meticulous enough and precise to check whether it's decompressed on the opposite side. For example, if it's a unilateral and you are going to plan a unilateral T-leaf, and you should be sure that the patient has unilateral symptoms. But it's a large, huge disc. It's better to check on both the sides and then do a interbody fusion.
So, but how do you decide? How do you say the opposite side? So you do a complete midline laminectomy and then
Midline
assess?
laminectomy and decompression.
Okay. So this was what was offered for the patient, and we had a very uneventful course. We mobilized the patient. Patient improved symptomatically. The claudication distance also improved, and this patient was asked to follow up at the 4 weeks time. And as usual, they did a suture removal at their native place, and patient presented at the end of 3 months with this finding. At the time of presentation, I must mention that the patient had a localized non-specific back pain which was on the suture line, which is there in the most of the patients, and there was no obvious radiculopathy. There was an intermittent some radiculopathy patient complaint, but no continuous pain. So Dr. Deepak, what would you like to do at this point of time?
Like to comment that we have to also see why it came back, and one of the reasons why it comes back is because sometimes we don't do a complete discectomy. We keep a lot of spongy disc inside, and that causes a pressure and it pushes the cage back. Secondly, now that we have this situation and the patient doesn't seem to have much symptoms, but you can't leave it like that because you don't know. But metal over the nerve, sometimes you can have a delayed onset neuropathy or weakness. So I have to take it out.
So I would frame and I would take a call from the all panelists on this side. What would they like to do? ABG sir, because patient has a minimal symptoms at this stage, what would be your approach?
Generally, surgeon has a tendency to put a larger and a longer cage. And this is what happens. If you look at the post-op X-ray of this same patient, the cage was actually out. It is going beyond the margins of the posterior margin of the vertebra. And as per the X-ray, it doesn't look like it is compressed. Right. So there are very high chances the cage has to get migrated posteriorly. This is what happened after maybe 3 months and later. Now it is an absolute unstable situation. You need to remove all the implants, put the cage again, but the larger size cage now. Length may be shorter, but thickness may be increased. Maybe you'll have to go a 12 millimeter cage. And screw you replace with the 1 millimeter thicker screw. That should be doing a good job.
Okay. And sir, regarding the a lot of time the disc space are collapsed, and when we try to pass an instrument, it becomes very difficult. So do you, when you are inserting the screw, you already inserted the screw, do you use any distraction of the screw to open up the disc space, or you purely go with the gradual release and then open up the disc?
Also, the pucca does the job.
Right.
Once you put the pucca and turn it, you will get
so it's very important point, sir, as highlighted, that you should not use a screw as a distraction maneuver because it can cause a lot of weakness of the screw purchase, and screw may get toggled. Dr. Sudhir, Do you have
At
any
this point of time, I would also like to do a CT to see whether there is some union occurring anterior to that cage. Because as such, this cage is not causing lot of problem. Basically, the body is posteriorly like this, curved. So probably it is not damaging much, but I would like to see if there is a union occurring there. Would just wait for some more time.
I agree with your opinion, but do you think 3 months is too early to see for a union, or you expect this kind
At
of?
least something should be happening there because you would have put a graft anterior to the cage, isn't it?
Okay.
So, and you have scraped the body also, the lower portion of. So there must be some activity going on. So there must be seen some biological activity. And if it is progressing, I'll give an additional brace and wait for some more time.
Arjun, a lot of time this happens that we put a cage, we do a thorough decompression, but in spite of that, patient do complain of persistent post-operative radiculopathy. You may call it an incomplete job, or you may call it as a chemical which is persistent. So how do you approach this situation? Not in this case, but if the patient, you do this procedure, patient has a persistent post-operative radiculopathy, how do you counsel? Do you do any pain control? Do you do any block? What are your indications in your practice?
So if the patient complains of persistent radiculopathy after surgery, then you need to investigate it. Beyond a point, you can give analgesics, give everything else. But before you plan any repeat intervention, whether it's a block or something, then I would definitely do labs to be sure that there's no infection, get a new MRI, if required with contrast, so that I have more information, and get a CT, so that we are able to understand for sure that our implant's in position, that there's no collection, that there's no early infection, that the labs are okay, and then plan treatment. I would not decide on any treatment without having all these things in place. And if the patient is functionally disabled, then obviously there has to be a revision. However difficult it is for the surgeon to accept, it has to be done for the patient's comfort. And it's best to be honest, explain everything to the patient, and then do whatever is required. So if there is implant loosening here, there are only two possibilities. One is the implant is backed, or secondly, there is infection. And then this is with time going to get worse. It's not going to get better. So it's better to deal with it before there's any neurology and take care of it.
So I think Dr. Sudhir, Sharan and Dr. Arjun are highlighted important point to do a CT scan, because a lot of time you get an inferior screw cut out of the pedicle, and that could be also a reason. There could be screws loosening, or there could be infection, which Arjun suggested. So I want to know from Dr. Badani, do you have any experience with the post-operative blocks in a TLIF patients? Do you have to practice, or what is your take on that? That patient has undergone a TLIF surgery and you need a block for the persistent radiculopathy.
Yeah, often I have given, because once you have confirmed that there is no other compressive cause, then we expect things like root inflammation, handling, etc. In those cases, the blocks are very helpful, because there could be some root inflammation. So that block can take care of that. So once you ruled out a compressive etiology, sometimes even is you find a small compressive, probable compressive reason, then blocks are useful.
So, Dr. Sandeep, a lot of time we do a TLIF from the left side, and patient comes back with a pain on a right side lower limb radiculopathy after a surgery, which was not there pre-operatively. So, how do you handle this technique, and what is the problem with the scenario?
So again, in this case, if I am not sure what is the exact cause, you deal with it like you deal with a fresh case, because this is an entirely new symptom which is appearing. Now, depending on, since we are on this topic of cage, the cage looks very fancy when it sits inside, but we need to understand the actual fusion surgery is anterior to the cage, right? So if I'm operating, more than 50% of your surgery time should be spent on preparing your end plate and doing a meticulous grafting into the interbody, and the cage is just for mechanical support till the anterior graft takes up. So your main grafting has to be anterior, so you have to go right up to the anterior longitudinal ligament to get the disc out, and these are very, very important points. Many times we have seen that we just put in a puka chisel, just rotate it 11 number and push in a cage, which is not going to fuse. So your end plate preparation has to be absolutely proper for you to have a good fusion.
Right. So with the paucity of time, I would proceed for this case. We kept on conserving this patient because patient did not have a significant symptom complex, and fortunately for us, as we expected, the cage was passed from the back side, it didn't back out and it stayed there, and we got a good fusion from the front side. So as Dr. Sandeep had highlighted, it's very important to do a good thorough end plate preparation. Please remember that you don't be very over aggressive while doing a curating of the end plates, because a lot of these elderly females are osteoporotic. As Dr. ABG sir highlighted, radiology is not the important thing. One has to also seek and clinically correlate these patients when you are deciding about the operative management. Observation and proper patient counseling, especially lumbar fusion surgery, which in Western countries have already raised a lot of objections to, is very important. Always mind osteoporosis. And another tip which even all the panelists mentioned is the compression once you pass the cage. And cage size and location is important. We want a lordosis put it in the front part, backside for a foraminal decompression, and avoid overstuffing to avoid the contralateral radiculopathy. Thank you for your patient listening.
Thank you, Dr. Tushar. Thank you very much for an excellent case. I would like to ask ABG sir, who's been a mentor to almost all of us over here, to summarize this particular session and wind up the session.
Lumbar decompression is one of the most common surgery. As somebody said, it is most rewarding also. Important is small technical issues, technical points must be learned before you just go ahead, because it is not that just go open, expose and take out the laminae. That is not enough. So many factors needs to be considered before you go ahead with the surgery. And if you take all these precautions in mind, probably you will not land up in a trouble. Thank you.
Thank you. Thank you very much. Over to the hall in charge, Dr. Dheeraj.
Questions?
There's a question over here. Yeah, please.
What is the treatment if the radicular pain persists after even surgery?
So may I pass this question to the senior panelist over here, Dr. Badani and ABG sir.
Yeah, so essentially you have to make sure that your decompression was adequate. There is no instability or anything that you have missed. So maybe you can investigate in those things. Once you find that your decompression is proper, then you'll have to, treatment will have to be medical. You could consider giving blocks, gabapentin like drugs. Many of these patients are often deficient in B12, etc. So we substitute that. Another very important thing is that you have to make sure that your primary indication was correct. If you operated on a patient where the compression was not sufficient enough to tell you that surgery will help, then you are treating a patient where whom the initial pathology itself was not compressive. So those things will have to be taken into account.
Patient operated 1 year back, all the investigation will carried out, the cause is not found. Still patient is complaining of pain persistently and is limping. What is the possible cause of it? What is the remedy for it?
So after the surgery, the pain persists.
Sorry?
That's correct. After the surgery, the pain continues.
Continues, absolutely. Absolutely.
So as Badani said, first, whether your indications were correct, one. Secondly, if you have done the instrumentation, you should find out whether you are causing any compression or now. Maybe CT scan will help you. Thirdly, there is a low-grade infection which is going on, which is not very florid, so we are not able to point it out quickly. Fourth is the amount of the handling of the nerve which has happened at the time of surgery itself is responsible for the long duration of a neurological symptom. All this can be, if there is no infection, you have to rule that out. And if the infection is not there, root block at maybe first once or twice may be helpful, and the pathology can get resolved. But if the actual iatrogenic damage to the nerve, you will not have much relief.
Also, many times, SI joint pathologies, hip pathologies, they are very, very much mimic. So you must make sure that, those things are also ruled out.
Sir,
Okay, I think we need to cut this session out because we are really running short of time. The questions from the audience can be addressed by the panelists after we get down from the stage. So thank you very much. We need to wind up the session.